Good morning, everyone, and thank you very much for attending this morning's mistake proofing report out. We were team, this is a standard work combination sheet for our presentation this morning. It indicates all the team members and the time we'll speak this morning. Our team was involved with the elimination of retained wound products on level 4, which is a surgical unit on the Victoria Hospital. A lot of our work was around the provincial alerts. There were 3 incidents in our region and incidents noted through other regions in which the province came up with a provincial alert, recommendations around how to eliminate this defect. So we're going to demonstrate this morning that the work that we did applying lean methodology around 3 work standards and 1 add-on, that we've addressed these recommendations around implementing procedures that require packing materials to be counted and documented, and wound care record that incorporates how and with the patient and as they flow, not only at the bedside, but accompanying the patient through all points of transfer, and staff to be trained on this process. There's a picture of our group. We met weekly and continuously. Mr. Graham Fass, Mr. Ian Johnson, Ms. Laura Jensen, and Ms. Eddie Stans, and myself. We have a dynamic group that was lots of work, and getting onto the Gemba with this crew was really a great journey in this process. Here's our, I'm nervous. Here's our project sheet, and again, it works through all us fine folks that were on this project, as well as some very key individuals involved with this and our context experts. Lavetta, who is our interstomal therapist in the region, Yvette Thomas, who works out of home care and heads up the wound care committee, and Lisa Rock is a registered nurse that's working in patient safety and quality. And we work with all these fine folks through this process. Our theme, again, was we focused on inconsistencies in practice that exist with patients that are at risk of having packing material retained, and to eliminate that defect, we focused on the flow of information, both on the unit and then in from the unit and off the unit, and we tried to maintain our focus on level 4, because that was where our main area was. You don't want to get too broad with these changes. So we looked at eliminating the defects again, and hopefully spreading this work throughout the system as well.
Okay. Good morning. I'm Laura Jensen. I work in the quality department. I'm just going to speak to our current state and some of our baseline data, so where we began the project. So this is our current state value stream map from back in June. You can see our process begins in the OR. That was, as Frank mentioned, kind of outside of our scope. So the dashed line shows what's within our scope is the patient being transferred from wherever they're having their surgery or their wounds being packed to level 4. The information is handed off from provider to provider on level 4 there. And the middle step is the wound packing being changed. So that dressing change happens ongoing throughout their stay. Might happen quite a number of times. And then ultimately the information is handed off when they're discharged home or transferred to home care. So some of the starbursts that we made note of here. Within the OR we had a few. Of course we made note those were outside of our scope, but we did try to investigate them a bit. We knew there was no space for packing details on the current wound record that was being used. We also knew there were several forms in use in different departments, and that it wasn't really consistently being used on the charts, even on level 4. We wanted to look at the inconsistent verbal handoffs at each of those transfers. There were out-of-date policies regarding wound care. There were no kits either in the OR or on level 4 for doing the wound care. And pieces of packing ultimately may be left in. It's the defect we were looking at, and that was a risk in the process we saw. So this is based on timings and spending time on the Gemba and talking with staff. So from the time we spent with staff, we discovered there were a lot of different contributing factors. We focused on 3 different areas. mostly on standards, communication, and documentation. We felt that those had the greatest risk of leading to retaining packing left in wounds, so we focused most of our energy in those areas. And I'll just go through our defect data. So we began with a mistake proofing level of 1 and a defect rate of 50%. That was with a relatively small sample size of dressing changes we had observed and charts that we reviewed on the unit. By the end of our project, we have a mistake proofing level of 3. And a defect rate of 21%. So we saw 58% improvement in those numbers. Now I'll just go through the target progress report to let you know our baseline numbers and where we were shooting for. First, our defect data. So I mentioned we had 50% pre-Kaizen and 21% post-Kaizen. For some context, there are an average of 36 patients coming onto that unit every week. We found about 1 a week was having wounds packed for us to observe. And there was one and-on pre-Kaizen, and that was for back dressings specifically. In the end, there were 2 and-ons. We spread that to all dressings that had packing. Work standards related to wound care, there were none on the unit pre-Kaizen and 3 now. So the defects that we measured under quality were the percentage of time that the wound record was on the chart. So starting from having it available to use at that first dressing change. So that was 100% defect rate because we hadn't implemented that yet. So pre-Kaizen we had 100% defect rate. Our target of course was 0. We also measured, and this was our main defect measure, the percentage of the time the wound record was not completed. So if the record wasn't on the chart and it wasn't completed, in this case 97% defect rate. So that number is a lot higher because we had the opportunity to review a lot of charts throughout the project and got a bigger sample size. And finally, the percentage of the time the and-on was not used was our third defect. Again, because we hadn't implemented that yet, it was 100% at the beginning. We did measure a cycle time, we did aim to reduce it. It wasn't something we focused on in our project because we were looking at quality and we didn't see the need to reduce the time that it was taking.
What you'll see in front of you now are some time observation forms. We did some timings of actual packed wound changes on level 4 so that we could understand the process. We then drew up some idea summary sheets for the problems identified in our value stream map. The first one shows the many forms and places, such as a whiteboard and wound record not consistently used, that clinicians had to search through to guide them in a dressing change, especially when packing was involved. We implemented a new wound record sheet and 3 work standards, and assigned that responsibility to all nursing staff to fill out. Page 2 of the wound record includes areas for packing details, such as amount of packing removed and inserted, along with the length and number of pieces. Details standard work to complete a wound record on a patient chart. The work standard details the standard work to complete a wound record on a patient chart to document each dressing change. The second standard explains how and where to document each dressing and process steps for using the packing add-on. Details for implementing the wound record were rolled out at staff huddles and posted on the department biz wall. The new wound record also addresses the problem of information lacking on patient handoff to other services such as home care, as well as gathering of relevant details from the initiating service such as the OR. We also created an and-on and work standard to quickly and easily identify how many pieces of packing are in the wound. That work standard, along with Sharpie markers, are posted on the main storage room dressing cart.
All right. Good morning, Ian Johnson from the Kaizen Promotion Office. We had an idea of implementing a wound record sheet into the patient chart. So one of the work standards we made was to have every patient chart have the wound record present in it. And you can see here's the work standard to be completed by the ward clerk. Every chart made has the wound record placed in it. And you can see we've got the training on the multi-skills training sheet. Now, it was discussed the possibility of kitting some of the dressing supplies and packing supplies, but it soon became evident that there was too many variables at this time with materials, the variations of the wounds, and the doctors. Also, they were discussing the possibility of a product picker, and that didn't fly here, but actually the OR was very interested in it. And the product picker was using radio-opaque packing materials so that if there was a case of any retained materials, it could be easily found through x-rays. And here's the idea sheet on that. And replicate or steal shamelessly, depends on which side of the fence you're on. Level 5 and level 6 already have a discharge plan in place, the work standard for this, and we are going to replicate that on level 4.
Good morning. My name is Graham Fast from the Health Quality Council in Saskatoon, and I'm a lead leader in training, and I was the player to be named later on this team. I just want to thank him for accepting me so openly. I'm presenting the post-Kaizen value stream map. As you can see, there's no overall change in the map details in terms of process steps. There is a change in the cycle time related to the wound packing process based on an observation post-Kaizen, but that's not related to our change strategies. And as you can see, that we have successfully addressed 5 of the starbursts on the value stream map. The first was that we have many forms in use, and there is now a single wound record with the information consistently reported that travels with the patients as they are transferred into home care. The second is the inconsistent verbal handoff, and the completion of the wound record every time the dressing is changed ensures that the information on the packing detail is consistently transferred to the next care provider. The third starburst is that there's no space for packing details on the record, and as you've heard, there is now a place on the wound record to record the type of packing, the number of strips, and the length of strips going in. The fourth starburst is the inconsistent handoffs as the patient is transferred to home care, and there is now a work standard to ensure that the wound record is faxed to home care on discharge, so the staff understand the details of the wound packing when they first change the packing in the patient's home. And the last one is around pieces of packing that could potentially be retained in the wound. And as you've heard, there is now a work standard that the person changing the dressing clearly marks the number of strips right on the dressing. This and-on ensures that the number of strips that are going into the wound are coming out. Next. So this is our post-target progress report. And as you've heard, the measures that we focused on were quality metrics. The first was the percentage of time that the wound record was not placed on the chart. Our baseline measurement was 100%, and our final audit showed 0% for 100% improvement. The second was the percent of time the wound record was not completed, and the baseline was 97%. The final measurement was 21% for a positive change of 76%. And the last was the percent of time that the ando was not used. The baseline was 100%. Our final was 33% for representing a positive change of 67%. So in terms of our newspaper, so we have 3 outstanding items on our project newspaper to close out in the next 30 days. The first is to receive the final approval on the draft wound record from the Wound Record Committee for use across the entire region. The second is for the mistake-proofing team members to follow up and close the loop on our project with the Wound Care Committee. And third is to complete the training in the new work standards and completing the multi-skills training checklists. And these are the actions that are required for us to achieve zero defects related to our quality metrics.
Thanks, and to summarize, we were able to implement a new wound record and have a single form in use. Also developed an and-on so that it's a very clear visual of what for the care providers as the providers hand off. Work standards for documenting as well as for the process of wound packing that'll follow the patient. I think one of the biggest things for us we found is how great the staff were up on level 4 and how engaged they were in the process and how much they value patient safety with this process. It's been a very good experience, and being on the Gemba, how important that is, and to get that engagement. So we have lots of thank yous. Again to Lavetta, our interstomal therapist, Melissa, who works as their desk nurse on level 4, and Yvette from home care, who's involved in the wound care committee. Jade is their discharge planner up there. All the nursing and all the staff up on level 4 for welcoming us and helping support this change. To Donna, thank you. Wound care committee and materials management for helping us. And a big thank you to Quentin, their nurse manager, Loretta, who's their nurse educator, and of course Cynthia, thank you very kindly for all your support and help with this mistake-proofing project. Thanks, everybody.